You say you see things that you've never seen before. What are some of those things that you're seeing?
When I initially started treating patients, I was under the impression, as most people were, that I was going to be treating acute respiratory distress syndrome that was similar in some sense to the ARDS that I saw as a fellow. And as I started to treat these patients, I witnessed things that are just unusual. And I'm sure doctors around the country are experiencing this. In the past, we don't see patients that are talking in full sentences and not complaining of overt shortness of breath with saturations in the high 70s. It's just not something we typically see. I've seen literally a saturation of 0 on a monitor, which is not something we ever want and something we actually actively try to avoid. The patients in front of me are unlike any patients I've ever seen. When we had a patient who had hit what we called our trigger to put in a breathing tube, meaning she had displayed a level of hypoxemia, of low oxygen levels, where we thought she would need a breathing tube. And most of the times when patients hit that level of hypoxemia, they're in distress and they can barely talk and they can't say complete sentences. And she could do all of those, and she did not want a breathing tube. And so she asked that we put it in at the last minute possible. And it was this perplexing clinical condition. When I was supposed to put the breathing tube in, when was the last minute possible? And all the instincts as a physician, we're looking to see if she, so-called tires out, if she's getting too tired. None of those things occurred. I came to realize that this condition is nothing I've ever seen before. And so I started to try to read. I sort of came upon decompression pulmonary sickness, which is, essentially the bends when divers dive and come up too quick, which seemed to have some kind of a mirror picture clinically as these patients. And then, in discussions with other people, it came up that, they do similarly appear clinically. And this is not to say that the pathophysiology underlying it is similar, but clinically they look a lot more like high altitude sickness than do pneumonia. And Gattinoni, he published something on March 20th. By the time I read what he was saying, I'd come under the impression that this just wasn't the usual ARDS that we were used to seeing. He's suggesting that the management strategy that we use is essentially somewhat flipped, at least in these high compliant patients. We may be not operating under the right paradigm, which is
how have you changed your protocols then?
So to be honest, I've run into a great deal of resistance within my institution. These are the protocols that are in every major hospital and minor hospital. I mean, we generally
you talked about in your videos,
yeah,
against long-standing dogma. So what's been the response from your clinical colleagues as well as hospital administrators?
So to be honest, in the ICU, I started to try to run not my own protocols, but to treat patients as I would have treated my family under with the different goals, which is to say a ventilation. However, these didn't fit the protocol. And the protocol is what the hospital runs on, what the respiratory therapists, what the nurses. I mean, everyone is part of the team. And so actually we ran into an impasse where I could not morally in a patient-doctor relationship, I could not continue the current protocols, which again are the protocols of the top hospitals in the country. But I could not continue those. And obviously they couldn't have someone, you can't have one doctor just doing their own protocol. So I actually had to step down from my position in the ICU. And so now I'm back in the ER. As far as how we're going to switch is we're going to take our approach differently from the traditional ARDSNet protocol, in that we are going to do an oxygen first strategy.